Perfect. Sorry about that little delay. We can see your slides.
Good.
Can you go to screen so you can see the whole screen?
So I must stop sharing. Huh?
No, don't. Jerry. There should be an icon that says full screen.
Doc, I think it's already on full screen mode.
Sorry?
It's already on full screen mode.
It is, it's on full screen mode. Perfect.
Yeah.
Without further ado, because we've had a bit of many of you are familiar with Erika Drewes. She's an integrative medicine doctor in Cape Town. Because we're running a little bit late, I'm not going to go through her full introduction, but she has an interest in chronic fatigue. And Erika, I'm just going to hand straight over to you, and then you can start presenting.
Sure. Hello, everyone. It's really nice to be with you guys again. I'm going to be talking on the chronic fatigue approach that I take in my clinical practice. I have been developing it over the last 5 or so years, and it seems to be getting really good results. I managed to help quite a lot of people with this approach, and I realized that it's probably different from other chronic fatigue approaches that you might have read about or had lectures about, but this is the way I do it, and that's why I also call it a clinical approach. I'm not claiming it for it to be the only approach, but hopefully there'll be some interesting ideas that you can apply in your practice. Okay. So when you're thinking about a patient that's got chronic fatigue, what I normally say to my patients is there are many moving parts. And when I come with a functional medicine approach, because it's a systems biology approach, I talk about the inside of a clock, and I say that, you know, there's multiple gears that have gone wrong, and that's why the clock is not running. And it's sometimes also daunting for a clinician to think about the insides of a machine and all the different parts, and where do you start to get this clock running. So this is my approach. I normally will start on the outside of the center and of the target, and then work my way towards the center. So on the slide, number 1 is at the bottom. I start with energy. I know a lot of people who've heard this talk before say that they start with gut work, but I feel you've got 2, maybe 3 visits from a patient where if you haven't moved the needle for them, they're not going to come back and they're not going to see it through. And patients are quite emotional. They maybe have been sick for many years, but when it comes to a new doctor, like I said, you've got 1 or 2 shots and then you needed to have made a difference. So I start with energy because that's the quickest way for someone to feel that you've really changed something for them. And so for energy, I do work a lot on thyroid and cortisol. I focus on neurotransmitters and mood. And then quite quickly on next to that, I start working on the mitochondria. Mitochondrial work is, I find, a bit slower than working on the hormones. So I start with hormones normally first. And oftentimes I'll say to patients that this might be enough. Like maybe if I see you in 2 months' time, you're going to be 90% better. And then I don't really need to push much further. But what I will do is if they do come back for the second or third follow-up and we're still in trouble, I start bringing in the reproductive balance, which is still very much part of looking at the hormone household. And then I start working on gut, including gut pathogens. And then I start chasing pathogens and toxins. And toxins could be mold toxicity. It could also be heavy metals toxicity, or toxins that are coming from chronic infections like Lyme's disease. So on this step 1, when we're looking at thyroid, as you all know, or probably don't know, mainstream medicine, we normally evaluate the thyroid stimulating hormone and the T4. We're not so much always testing routinely the T3 or thyroid antibodies. But when you work with functional medicine, and especially in this subgroup of patients, it's actually important to measure all of the different metrics of the thyroid. You can find patients with positive antibodies with normal thyroid functions. That's been known to happen. You can also have a deceptively normal TSH with very low T4 and T3 levels. So I think it's really important to evaluate the full thyroid. A lot of people also look at the reverse T3. I find it quite an expensive test, and the lower your T3 is normally, the higher the reverse T3 is. So I tend to just do the T3, and then if that's very low, I assume that the T3 is quite high. So I do that to try and save a little bit on cash for the patient. So one of the things that a lot of people don't realize, especially when you're dealing with a chronic fatigue patient, when you do your physical exam on them, you'll notice that their body temperatures will be on the low side. Some of them will have body temperatures of 35 degrees. Anything under 36.7 is actually very cool, and that's often a sign of peripheral poor thyroid function. I mean, you can also look at peripheral edema. The clinical picture is really important. Pretibial edema. You can look at the lateral eyebrow loss, the peaches and cream complexion. Patients often will tell you that their hair is consistently falling out. They struggle with waking up in the morning. That morning fatigue is usually, for me, pathognomonic. I go on that quite strongly. If patients tell me they can't get going in the morning, I often know that there is a thyroid problem. So for me, the clinical picture always trumps what I find on the blood tests. And you will see with chronic fatigue patients, they all have hallmarks of low thyroid. And the reason for that is, and it's a complicated picture, but what they're basically showing in this picture is that you can have a normal blood test for somebody who still has low thyroid. So how would that work? Well, in the pituitary cell, which is now in the brain, you have type 2 deiodinase enzymes, which are increased, and they have got this ability to convert T4 to T3, which satisfy the requirements for thyroid hormone in the brain. And that's why the TSH will actually fall out normal when you do this blood test. But in the rest of the body, you don't actually have type 2 deiodinase. You only have type 1 and type 3. And what that basically results in is that when the body comes under stress, in the peripheral cell, the conversion of T4 to T3 is actually decreased, and there's an increase in the reverse T3 production. And that then leads to this peripheral clinical hypothyroidism. And you see this quite common in these conditions that are listed in the middle of the slide. So you see it in diabetes, depression, patients who diet consistently. There's been lots of studies shown that their T3 levels actually drop, and when they return back from the diet, their T3 levels don't necessarily recover when they start eating more calories in the diet. A chronic inflammation, which is what we know these chronic fatigue patients have, stress, which is what we know they have, obesity is also something that a lot of them struggle with. A lot of them have got the hormonal imbalances of PMS and leptin resistance. A lot of them have autoimmune disease. A lot of them have insulin resistance. And then obviously the whole group of them together will have this problem in common. So here's just another a visual depiction of how unreliable it actually is just to look at the blood tests well, specifically the T4 and the TSH. The testing accuracy actually decreases the sicker the person becomes. So the more severe the cellular uptake reduction is, the less sensitive the TSH and the T4 levels are in terms of you can't rely on them. But you can actually look at the T3, and then you can look at the T3, reverse T3 ratio. For me, as somebody working in lower resource setting in an African context, I try to not over investigate. So I do rely on clinical signs and symptoms when I look at this. And so I do place a big focus on T3 in my practice. Obviously, one has to do whatever you can to support the thyroid before you give any thyroid replacement. And you obviously have to control against the T3 and the T4 blood levels to make sure that if you are going to do a replacement, that you're not going to over-replace. I tend to first start with iodine, and this is something that is a recent addition to my protocol. What a lot of people don't realize is that we actually in Africa, especially in Central Africa, we really don't have good iodine in our soils. It is thought that at the last interglacial period, when the ice caps melted, a lot of the topsoil of the central continents actually ended up in the ocean, and a lot of iodine got lost like that. So we have a lot of iodine in the ocean, but we don't have a lot in the central parts of Africa. And I came across this really wonderful paper that was written in 1954, where they tested soils all the way from Northern Africa, Kenya, Uganda, all the way south, Zimbabwe, and also South Africa, showing how depleted the soils are of iodine. So in Japan, where people eat quite a lot of algae, they take in on average about 12 milligrams of iodine in their diet per day. The recommended daily allowance for iodine is about 150 micrograms. So that's vastly less than what they would be taking in Japan. But interestingly, in Japan, they've got the lowest rates of autoimmune thyroiditis in the world. What I have started doing is I have got access to a lab in George, where I can send urine levels to see if my patients have got iodine deficiency. And I've established that while a lot of them have got low levels, I've not yet found anybody that's got no iodine. So I tend to replace at about 500 micrograms a day, and if I need to, I'll work up to about a gram a day. About 1,000 micrograms, so 1 milligram a day. And that makes a huge difference to thyroid replacement needs. Often patients don't need so much, and you can actually when they come back after a month, they often tell you they feel so much better. The energy levels are feeling better. So for me, that's a nice cheap tip. We normally work with compounded Lugol's iodine, but there are kelp extracts. I think a kelp extract can get you about 300 micrograms. And then if the iodine doesn't work, I'll tend to move on to maybe some slow release T3. If the deficiency is quite severe, and usually I'll have blood levels to prove it as well, I'll go in with prescription meds. Once I've started addressing the thyroid, I'm definitely already helping patients. They often say they feel so much better. But in addition to looking at the thyroid, I also look at the hypothalamic pituitary adrenal axis, and I look at their sleep. I measure cortisol, free testosterone, and DHEA as the three main hormones to look at HPA axis. A lot of work on HPA axis dysregulation was done by Dr. Bruce McEwen and his group. They basically looked at, they inputted different things that stress a person, where you would have an adaptive stress response, a physiologic stress response, and then they would look at the metrics, and they were able to show that over time, the adaptation that the body has to undergo with the recovery phase, where cortisol levels go up and down, tends to become blunted. So there's a slower response when a person needs that physiological response, and over time, the recovery time also slows down. So you can end up with very deranged cortisol patterns. So I'm not talking Addison's or Cushing's, I'm talking of derangements within the normal. So a normal cortisol can be anything between 50 and 550, depending on which lab you use. And I'm talking about derangements within this within this interval. And you often see the patients coming in falling somewhere on this graph. So this is just a visual depiction of the kinds of pictures that you can get with hypothalamic pituitary axis dysregulation. So if you look at the normal, you see that this is a person that's got homeostasis. So in times of stress, the cortisol can go up and the cortisol can come down because there's adequate response and recovery. Then at some point, resistance starts setting in. And in this phase, and I normally see this in younger people who've got a lot more resilience, you'll see that their cortisols are falling out at the higher side of the range, say maybe over 400 to 500, maybe sometimes even over 500. I often see this in young women with PCOS or, stressed university students. And when you talk to them, they'll also say to you, I'm wired, I can't switch off, I'm lying awake at night, my mind is racing, I can't come down, but I'm so exhausted on the inside because they can't come down from these high cortisol levels. Then the next step on, if that situation isn't rectified, you start having this dysregulated pattern where you have cortisols that are, the pattern is supposed to be a higher pattern in the morning with a gentle slope throughout the midday and then a little recovery bump towards the end of the day. But when you get to the stage 3, there's an attempted adaptation, but the pattern is dysregulated. So these patients are tired in the morning. They sometimes feel like they have to have a nap in the afternoon. And oftentimes they have this little second wind at about 6 p.m. where the little cortisol recovery bump steps in, and then they grab all their work. They do everything that they didn't do throughout the day and they try and catch up. And that's when the cortisol sometimes can go too high again. So you would use different adaptogens depending on where the patient is on this graph. And then the final phase is this exhaustion phase where there's no bumps anymore. It's just a flat line for these patients. They're tired the whole day. They can't seem to sleep enough. They wake up and they're just exhausted all the time. In this red block is where you often find the autoimmune disease, and this also where you start seeing the treatment-resistant depressions and things. So these are the people that we normally see as the classic chronic fatigue patients. So this is just, I'm not going to spend too much time on this because you'll be able to grab this afterwards from the recording. But with the different stages of fatigue, you would use different things. So where the cortisols are high, you'll be using nutrients that are calming, nutrients that will, we've got some nice studies, for example, on ashwagandha showing how it brings down cortisol over time with each month of use. With stage 2 and 3, you won't just bring cortisol down, you'll try and energize in the morning. So you might use ginseng, you might use rhodiola. Stage 3 to 4, you need the big guns. So you need actual glandular extracts, which are available from most of the health shops. They're usually from bovine sources. So I tend to use adrenogen from Metagenics. But then you also need to pay attention to low testosterone. I sometimes use 7-keto-pregnenolone to try and boost the testosterone. Sometimes I give testosterone replacement. And then you must remember the neurotransmitters with each of these stages. There will be different depletions. With stage 1, usually GABA is depleted. Stage 2, serotonin. And stage 3, you will have dopamine, adrenaline, noradrenaline, in addition to the other two being depleted. And you can replete these with using amino acids, but you could also, sometimes you need to, write the person a sertraline script, or even a Wellbutrin script to boost the dopamine, depending on how severe it is and how much you can do to help them. And in the short term, you want them to feel better. You want them to feel like they can do this. Otherwise, they're going to give up and you're not going to be able to make any progress with them. So the third step that's really important when you are working on patients with chronic fatigue is you've got to recognize that they do have a baseline hypercoagulable state. And often when you test them, So then it's not that they've got clots or anything, it's more just that there's increased blood viscosity. And I'll explain to you now, some of the studies on this. But we often, the poor man's test is an erythrocyte sedimentation rate of less than 4, will, indicate that there might be a viscosity problem. Sometimes these patients have got low-grade increased D-dimers. So if on my labs, it will be something like 500 or 600. Normal being under 500. Sometimes I have 700s. And, when it starts going into the thousands, I do start worrying about clots. And often you see this in patients in the long COVID. So patients who, they had COVID 2-3 years ago, and now they're coming in with these raised dimers, and they tell you also that they can't think straight. They feel like they don't get enough oxygen to the brain, and they start to feel short of breath, especially on exertion. They struggle to go upstairs. They struggle to get exercising. They get extremely short of breath. I'll explain to you now how that works as well. And then often fibrinogen's low. Sometimes they can see the clotting, especially within COVID. There's been a lot of complementary doctors who do dark field microscopy, and they can show you the rouleau formation of how these red blood cells tend to clump together. But like I said, this is not a new thing. COVID maybe highlighted it, but back in 1999, we already had Dr. Berg and his research group who started looking at chronic fatigue patients. And they showed that quite a significant percentage of patients in this study had antiphospholipid syndrome hallmarks when they tested them. And a lot of chronic fatigue patients have got what they call immune activation of clotting, which it's coming on the next slide. So I did say to you, shortness of breath, brain fog, fatigue, cold extremities, and it can improve instantly if you give them something to facilitate blood flow. A lot of these symptoms can improve. So what you see is when you look at the red blood cells, they're about 7 microns in diameter versus the 14 microns of white blood cells. So they're much, much smaller. And if you imagine now tiny little arterioles where the cells need to move through one cell at a time, there'll be a log jam, and these erythrocytes won't be able to move through. And this results in the decrease of diffusion. So instead of having 2 seconds of oxygen just leaving the erythrocyte, diffusing into the tissue and being able to pick up CO2, this is now slowed down to 5.3 minutes. And so it's significant, the oxygen deficiency that can come with this condition. And then if you add to that a lot of these patients also have they have infections, you can see how this clotting cascade can get activated. So this is a study just on activated protein C and how this can help with the hypocoagulable state of infection. So we're not interested in the protein C. I thought the picture is actually quite a good one. So you look on the left-hand side, you can see the trigger coming through: bacteria, virus, fungus, or parasite. And this then activates your monocyte, which then triggers all these different cytokines to get released, and tissue factor activating the clotting cascade with factor 8A and factor 5 activated then the thrombin, which then leads to fibrin creation and deposition. And this is something that is part and parcel of what you're seeing with patients who, for example, have chronic Epstein-Barr infection or other infections that tend to persist. The Lyme's disease would also fall into this category. Patients with Bartonella infection, patients with babesiosis. And then, of course, the whole long COVID thing also comes into play. So I'm quite lucky. I can send bloods. I can send my patients to participate in a microclot study at Stellenbosch University, which is done. There's a local physician who's working with Stellenbosch, and he looks after all of the trial patients. So the patients go through and they have electron microscopy done on their blood. and you can see these activated platelets, abnormally activated platelets, and abnormal erythrocytes. And what they normally do is they grade it in terms of severity, and the patients are then enrolled, and he actually gives them 3 kinds of anti-clotting medications, something for platelets, but also something that inhibits the different clotting factors. So I think the classic combination is clopidogrel plus, and I think they sometimes use Xarelto as well, and Eliquis. So quite a robust regime, which is, I'm very happy to have a physician on board for that. I know I get nervous with all those drugs. I would normally, on my side, I would work with something like the proteolytic enzymes, so something like serrapeptase or nattokinase. Sometimes I would work with aspirin. There's been some work by Dr. Scheim with Jackie where they published on ivermectin, also breaking down some of the microclots associated with spike. So those are all interesting modalities that you can work with. And then the next thing that I go after, if patients still haven't responded to the first few things and they're not really well on their way to getting better, I get into the immune system. I send off a CD57 Lyme to Ampath, which is, it's not indicative that the patient's got Lyme's disease, but it often is exhausted in patients with a chronic infection. So anything under 150 is usually, it means that there's some depletion. I like doing it as a baseline because I have got a high-dose vitamin C IV protocol that I use with these patients, and I like to retest them after about 3 months on these infusions, and I often find that the CD57 has improved, and that really encourages them because they all feel quite nervous about their immune systems. If you can have access to cytokine profiles, that's usually very helpful. But in South Africa, you know, the most I can get is interleukin-6, not really much more. What I wanted to show to you just on the next slide is something to understand about patients who have got this type of clinical picture, is that there is a shift to Th2 responses in patients with chronic fatigue syndrome. So normally your innate immunity that forms part of your Th1 immune response is what takes care of external pathogens coming in. They want to make you sick. But in a patient where you've got established disease and where they maybe have had a chronic infection for quite a long time, this Th1 response can become depleted, and then there is a shift towards the adaptive immunity, almost overreacting to try and protect the organism. So you'll find that the cells types and the cytokines associated with the Th2 response, which is what you see here on the left, will be increased in patients with these conditions, and there'll be diminished cellular immunity, and you will have high cytokines which are self-reinforcing. So the higher they go, the more they recruit cells to the area, and the more the other cells also start producing the same things. And this is actually not a good state to be in. This is also where the patients start developing the mast cell disorders, mast cell activation disorder, and this is also where they develop autoimmune disease. So a lot of this work was done also in the late 90s, and they've shown especially in patients with HIV infection, that this seems to be a shift. And so the more you have this type 2 response, the worse it is for the patients and the worse the outcomes are. Looking at your chronic fatigue patient, you need to think about these shifts in the immune system, and you need to do things to try and shift them towards supporting the Th1 system. So with that, there's lots of modalities, and what's wonderful about the immune system is there's a lot of non-drug modalities that can be used. So a lot of my patients go for limbic retraining, where we're really trying to balance the limbic system. A lot of patients go for trauma counseling. There's often a trauma story involved with these patients, and they're stuck in a sympathetic overdrive. So for these patients, engaging with therapies where they're doing breathing, or where they're doing grounding, or they're doing sport and they laugh and they find social connection, all those sorts of things are actually really powerful to modulate your immunity. You don't always need fancy supplements or drugs. You definitely could look at low-dose naltrexone. I like to use that, especially in a patient with chronic pain. That's maybe a talk on its own. I'm not going to spend too much time on that. Transfer factors are options. Quercetin, we all know and remember from COVID, is quite a good modulator. I really like using Moducare. I don't know if you guys have Moducare in your countries, but in South Africa, it's one of the oldest supplements on the market. You can buy it off the shelf in almost any pharmacy, and it's plant sterols and stereolins, and there's really good data on that. So if you have one of those patients who just tell you, doc, I get sick all the time, I just move from the one infection to the next, that's a really lovely product to bring in. A lot of people go, they nebulize with nano silver. I think Dr. Jackie has done quite a lot of presentations on that for us. We've got hyperbaric oxygen, and then I also have access to peptide therapies that can be used, obviously supporting vitamin D, supporting vitamin C, zinc. Sometimes I bring them in for IV infusions, and then some of the SSRIs have also been shown to modulate this inflammation. I'm not going to spend too much time on LDN. I want to just move on to the next bit, which is looking at mitochondrial stress. Mitochondria, it's part of energy, but it's also part of immune, and it's got a lot to do. The more your cells can produce ATP, the more the organism will also be able to get the chronic infections under control. So there is a free radical urine test strip that you can get from your Wellbeing in South Africa, malondialdehyde, which is a measure of the amount of free radicals in the system. And so it's a side room investigation. It's not very expensive. I think you can also get it online from certain companies in India. So that's a lovely thing that you could use maybe in your practice to see how bad the oxidative stress is in the patient. If they've got a little bit more money, you can go onto the Nordic platform, which is a big international functional medicine test platform. Or even in South Africa, you can use biometrics, and you can order an organic acid test for them, which is also a urine test. And with that, they do quite a lot of organic acid markers that looks at mitochondrial function, and then helps you specifically to repair it. But if you don't have access to a lot of tests and you just want to support the mitochondria, there's a lot of things to bear in mind. So one of the first things you need to realize is that there are quite a few membranes involved when you look at a mitochondria, and all these membranes consist of phospholipids. And when you have a patient with chronic fatigue, and especially if they've been exposed to toxins that can traverse the cell membrane and actually penetrate the nucleus and even damage the mitochondria, you're going to end up with membrane damage. And the person, one of the people who've done the most work on this is a Professor Garth Nicholson, who was tasked by the US Defense Force to look into Gulf War syndrome. So at the end of that Gulf War, a lot of soldiers came back to the US suffering with what looked like it could be Lyme's disease or a chronic fatigue syndrome, and they thought that maybe the patients had been exposed to something, but they weren't quite sure what, and they got Professor Nicholson to investigate it. And there was definitely this think that maybe they had been exposed to a weaponized bacteria. They managed to culture quite an aggressive form of Mycoplasma pneumoniae, and Mycoplasma is actually quite an interesting bug because it is cell wall deficient, and it needs to co-opt our cells to survive. But this infection, when once it's actually quite strongly established, is very damaging to the membranes. And so just giving the patient antibiotics for the mycoplasma is not enough. You do need to work on the lipid membrane. So Professor Nicholson, together with a couple of other pioneers, also Patricia Kane, they came up with this notion of phospholipid replacement therapy. So the idea is to give your patient phospholipids, the good new phospholipids that you give to the patient will obviously get into the circulation and, so to speak, flood the membranes. And there will be a natural parts exchange that happens. That is actually how our cell membranes work. Even with other fatty acids, whether it's omega-3s or omega-6s or saturated fats, whatever fat you use to flood the membranes with, the parts exchange will happen. And you need to have a squidgy, soft membrane for a good exchange to happen for the cells. So for it to get rid of toxins, but also for it to take up nutrients. And in the case of the mitochondria, for that mitochondria to work well in order to produce ATP. If you have a patient who's eating the wrong kind of fats, you're going to end up with quite a stiff cell membrane, and cell respiration will not be very good. So you want like a really nice, soft, gooey, like my cheek, membrane that can handle the cross traffic. And so phospholipids are a mainstay in my practice. So I give the patients oral phospholipids, phosphatidylcholine or phosphatidylserine, but I sometimes will also do it intravenously with phospholipid exchanges, together with all of the nutrients that the mitochondria need. And a picture like this, quite overwhelming, but it shows you, how important a lot of these cofactors are. So you need to make sure your patient is being supported with them. Then I think I've already mentioned the infusions for the mitochondrial support. The only other nutrient that I haven't mentioned yet is methylene blue. That's become quite a big hit in the post-COVID world. Methylene blue has been around for more than 100 years. Originally, it's the original dye of blue jeans. But Paul Ehrlich discovered that pharmaceutical grade methylene blue works quite well for malaria, and that's how it became a pharmacological agent. And with the advent of the development of antibiotics, agents like methylene blue fell by the wayside. But methylene blue is quite interesting in that it's a super circulator of electrons. It can donate electrons and then take them up and then donate them again, which makes it the only proper antidote for cyanide poisoning. So it's actually usually in your essential drug list. Most emergency departments should have IV methylene blue for that patient who might show up with cyanide poisoning because of this ability to cycle electrons. And then it's also used as a dye and contrast medium in imaging studies, but in our case, we're using it for mitochondrial support in the brain. So the patients often feel that COVID brain fog gets a lot better when they use methylene blue. With reproductive health, I have spoken to you about testosterone again, but I do, especially in females, I make sure, if they're postmenopausal, I get them onto HRT. If they're perimenopausal, I do whatever I can to support them there with either herbal supports or even progesterone. And then a big one is this unstable blood sugar situation. A lot of chronic fatigue patients are struggling with their weight. A lot of them are overeating carbohydrates because they're just feeling so tired the whole time. So they're craving sugars and sweet things. And when you test them, you find out they often are pre-diabetic. And when you just take them off the sugar roller coaster and you put them more towards a low-carb diet or a ketogenic diet, you take these huge hypoglycemic dips away for them, a huge shift in their energy then also appears. So I do like using bioidentical progesterone where indicated appropriately. I find it just such a wonderful agent that's been looked at in so many different contexts. They don't just use it in the context of female hormone replacement. It's also been tested for the nervous system, for myelin repair. They've looked at it in the context of traumatic brain injury. So anywhere where you've got maybe some neurodegenerative changes, if it's appropriate, you should be looking at implementing that for the patient because that is just a beautiful support for the neuronal system. Then the next slide, I want to just talk to you a little bit about digestive health. So this is usually where people really, the biggest criticism that I've had when I shared my approach with people is, why don't you start on gut? But I just explain that to you now, why I think that it's important to start with energy first. But then very much soon after that, I will get into digestive health. So these patients have got often very imbalanced microbiomes, but they also often have parasites and pathogens in the gut. So I think history is really important. Find out if they have any signs and symptoms of Helicobacter pylori. It's an underestimated foe. And if you treat Helicobacter pylori properly for somebody, and by properly, I mean the way that Dr. Barodi spoke about when he did the lectures here a few months ago, then you can shift a lot of things for patients. Helicobacter pylori is more than 40% of the world population has got it. And I think in Africa, the rates are even higher. I think it's closer to 70% in some groups. And it just is very much associated with autoimmune disease. These patients have definitely got an extra layer of fatigue that they struggle with. They have the gut symptoms that they struggle with, and then there's this other things that can be associated with it, for example, preeclampsia and thyroid disorders like Hashimoto's thyroiditis and Graves' disease, and also certain lymphomas. And then, of course, it is a carcinogen, being associated with stomach cancer, gastric carcinoma. So definitely very important to properly test your patient for that. So I routinely test every single patient I see for H. pylori, because it's often they don't have symptoms. It's often an asymptomatic infection. They are just tired with maybe a thyroid disorder, but they don't have the reflux or anything like that. I will look at digestion. I will look at elastase and steatocrit. A steatocrit is sometimes a poor man's test to see if the patient's got chronic Giardia infection. Giardia is another very common parasite that we can get from our pets. I think I've got a slide coming up on that. But a high steatocrit will point to fat malabsorption, which is a very common side effect. And these patients often have lactose intolerance as well. They tell you that they, or just different food intolerances. And then if you treat them with the correct antiparasitics, a lot of these issues go away. If you're not sure, you need to send your patients for endoscopies. I think it's anyway good practice just to rule out malignancies. If the patient can afford, it's really helpful to do one of these advanced stool panels, for example, Viome or the GI map you can also get on the Nordic platform or with Biometrics Laboratory. It's really important to pay attention to the different keystone bacterias and try and rehabilitate them with diet and pre and probiotics. But first, get rid of the pathogens. So I think I did mention to you a little bit about different parasites that you can just get from household pets. Giardia is the one that I think is underestimated. A lot of patients, even cats, cat lovers, will have chronic Giardia, and a second to H. pylori, it's the second most common infection that I come across, and it's often like a miracle if I give my patients the albendazole. Really makes them better. You can use metronidazole also for the Giardia, but these days it's harder to get rid of, and you need to use higher doses plus the side effects. So I tend to go for the albendazole. I find that works quite well. For blastocystis hominis, which is probably the third most common infection, ivermectin, there's some nice studies on ivermectin that shows that blastocystis hominis can be get rid of with ivermectin or nitazoxanide. I find blastocystis will also respond to metronidazole, but also again, you probably need longer courses to treat that effectively. I think I've spent a lot of time talking to you about Helicobacter. So just this slide just shows you where Helicobacter has been isolated from. And I think when Dr. Barodi did his presentation, he said that there was over 30 different kinds of Helicobacter now available, and that you shouldn't just assume that it's located in the stomach. There is some of these different variances of H. pylori are located in the bile or in the liver or in the pancreas, but this picture actually shows you where they've isolated it from. So sometimes I actually like to do the serum IgG screening test in patients who've never been treated before, because the antibodies will show up even if the infection's not in the gut. Whereas if you do a gut test, a stool test, and the infection's somewhere else, you might miss it. And even the urease breath test, you might miss it. So that's just helpful to think about. The next thing I go for is systemic infections. At this point, you start wondering, if your patient's still not better, you've worked on the gut, you've worked on the infections, you start wondering now, do these patients maybe have other parasites? Do they maybe have babesiosis? Do they maybe have Lyme's disease? I don't think I can go into detail tonight about that, but I'll just show you just broadly, if you want to get started, what you should be thinking about. This is just sorry, the slide's in German, but I think you can work out the names of all the different pathogens. But all the ones that are underlined on the slide are the most common ones that you should be thinking about, that commonly show up in patients who get tested from European doctors who are tropical diseases experts. So I've done a lot of training with German doctors, and these are their top pathogens. I think in South Africa we should have rickettsias a little bit higher on the list. I think a lot of patients have got chronic rickettsia infection. I commonly see the ureaplasma, so think about them when you have patients who tell you that somebody's diagnosed them with an irritable bladder, or they're peeing all the time. I think Ampath and PathCare have got really nice PCR panels on urine that you can do to look at chlamydia and ureaplasma infections. And it's really important to find them because they create the same sort of damage as mycoplasma. So exactly what I told you about mycoplasma goes for these two pathogens as well. Helicobacter we've spoken about. And then Borrelia, that's the classic Lyme's disease. We are seeing cases of it in South Africa. There's a couple of other clinicians and I who have patients, and sometimes they get their blood sent overseas, and we pick up Lyme's disease, even though they hadn't necessarily traveled. So that's quite an interesting thing. I think entomology and microbiology maybe should start looking at this. Because typically we're not supposed to see it in South Africa. We're supposed to just have rickettsia. And then Bartonella is another one we can also often pick up from our pets, which is the cat scratch disease. Again, not just two kinds. I mean, I think we were taught at med school Quintana and Henselinea are the common ones, which is the trench fever and cat scratch, but there's now also over 30 different kinds. They're also a lecture on their own. I could maybe come back at some point and do just a talk on Bartonella. Very fascinating. Yeah, the rest are less common, but the ones I've just highlighted, very common. It's overwhelming to know which ones to test for, so it is helpful to know your clinical presentations very well. To know what they look like and what's pathognomonic and what's not. You can also use things like this Armin Labs questionnaire checklist. The other one, German Deutsches Chronikerlabor, also have a checklist, and you fill it in depending on the symptoms, and it's an automated spreadsheet that will give you a ranking, and the top 3 are usually the ones that are most common that you should be checking for and testing for. You can download it from that link. Yeah, and then once you've identified it, you can start treating them. I tend to use a mix. It depends on the patient. If I have a patient with really bad gut issues, maybe they had multiple antibiotics before and you don't really want to give them more antibiotics, you can try and work with some of these herbs that I've listed here. There's actually a huge amounts of herbs available and herbal compounds. These are just a few. The methylene blue actually breaks biofilm. So it's been shown in some in vitro studies to eradicate Lyme's disease, also really good for Bartonella. you can then also look at anti-malarial type approaches if you're suspecting something like Babesia, which looks like malaria. They call it malaria of the north. It also infects your red blood cell. So working with wormwood, artemisias, or any of the malaria drugs, you can often get that patient quite a lot better. Again, that's a presentation on its own. I'll probably have to come back to talk to you about that. And then remember that the patients will have more than one thing. Remember what we spoke about, that Th1 response that's depleted, the cellular immunity. So when that happens, all the critters come out to play. So you'll have low-grade active Epstein-Barr virus. You might have some CMV. You might have some Coxsackie, plus, positive rickettsia plus a positive Babesia. You'll see them so together. But what you do is you focus on the bigger organism, the more intelligent organism that can modulate the system the most or interfere with it the most, like the H. pylori or the Babesia. And as you do that, you actually take the handbrake off that problem in the immune system, and then often the immune system can take care of the viruses on its own. So you don't always have to pick them off one by one. You just have to start with a really good strategy. And then what I also do is I work with patients with intravenous vitamin C, high dose vitamin C, with agents to break biofilm, and that works really well, also as a support. Yeah, so I'm basically at the end of my talk. This is just a summary of everything that I've taken you through. I think what's important is to remember not to be overzealous with eradication and detoxification, because I told you these patients, when they have this dysregulated immune system, if you cause a huge cytokine flare, you can trigger autoimmune responses with them. You can trigger, a dip that can last for months. Mast cell flare can last for months. So be very careful, be gentle with these patients. Less is more. And it didn't take them one day to get sick. You need to pace them. You need to manage their expectations. You need to say to them, I need to see you every month. Every month I see you, I'm going to peel another layer off the onion. You've got to do what I say. Stick with me, but don't go in too hard. More is not more. And then also remember that you want to get them to a place where they can just actually function. Sometimes just a few things are needed, and other times you really have to throw the kitchen sink at it. But if you can get them back to their studies, if they hadn't been able to study before, or but they still need a drip once a month to stay well, then you've done very well, because a lot of the damage to the cells and the immune system can be permanent. So, but always be hopeful, always be positive for them, because they are quite desperate when you see them. And that's the end of my talk. I hope I didn't overwhelm you too much. Thank you. Do you guys want to do any questions?
Thanks,
Jackie?
Erika. Sorry, I couldn't, my unmute button wouldn't work. That was brilliant. Thank you so much. You've had lots of compliments in the group. Is there anybody specifically who wants to ask a question? I'm looking in the chat at the moment. My computer's just a little bit slow at the moment. No, just lots and lots of compliments. Well done.
Thank you. Thank you very much. I appreciate it.
Okay, I am aware that it is 7:30 now, so let's close the talk down. And then I hope everybody enjoyed that. I certainly learned an enormous amount. I didn't know that albendazole was a treatment option for Giardia, but that's a very, very useful thing to use because metronidazole is such an unpleasant drug to actually have to prescribe it. How many days of albendazole would you use?
Well, the recommendation, actually, when you look up in the SAMF, it's 400 milligrams daily for 5 days. What I sometimes do is I give patients an empirical course. So in Germany, people send antibody titers to either in Hamburg, the Tropical Diseases Institute, or to other labs, and then they will test based on what parasites they find. But again, in the low resource setting, we don't necessarily have the money, and we know with a stool test for parasites, you need at least 3 stool samples, and then if you're lucky, you might see the parasite. So I tend to sometimes just do empirical, especially if patients have got pets that they in close contact with. So I'll do the 5 days of albendazole, and I'll get feedback from them. So if they say to me, you know what, doc, my gut's been regular, my constipation's gone, then I'll leave it at that. But other times I have patients where maybe they've been overseas, maybe they went to the Amazon and they picked up a giardia there, and they come back, and I do a full blood count, and that eosinophil count is high, which is, remember, that's also that poor man's test for a parasite. And then what I'll do is I'll actually follow the eosinophil count, and sometimes I actually have to repeat. So that's a long answer to your question, but sometimes the 5 days isn't enough, and you need to repeat the course sometimes more than once.
So 400 milligrams a day for 5 days.
Yes. Yes.
Perfect. If you were to combine it with ivermectin, would you cover your other gut parasites as well?
But remember, albendazole, it covers strongyloides, your filariasis, and all your worms. So I know that some docs actually have protocols where they combine. So they'll have maybe some albendazole, and then they'll go into maybe some ivermectin after that, and then maybe even some mebendazole after that. And they sometimes do a whole gut protocol for 1 month. The problem with that is that I don't think we've got a lot of data on that.
Yeah. But by the time you get the data, the patient is no better.
Yeah. What I like about ivermectin is the blastocystis hominis angle. There's some nice papers on that, because blastocystis can become quite a problem for some patients too.
Yeah. Are they usually symptomatic?
Yes, they're usually the patient with bloating, constipation, chronic bloating, chronic constipation. So often they come to you with functional medicine stuff that they've, picked up. So they'll say, I've got SIBO and I want rifaximin or something like that. But then if you take a good history and you see that they're in contact with pets often, I think it's a good place to start. It's much easier than doing a whole, big elimination diet. And it's a good place to start, just to think about parasites.
Great. Well, thanks very much for that. I'm going to end the call there. Pride, you can stop recording.
I think he has.
Indeed.
Oh.